One. So we are live now. Please start the session.
Okay. So good evening, everyone, and welcome to the BOS Rising Star 2025 program. I think this is the third year of BOS Rising Star, and this initiative was created with a simple but important objective to identify, encourage, and promote young orthopedic surgeons to show their academic acumen, to show their clarity of thought process, and commitment to learning. So I think in last 2 years, this program has been very popular, and it's not just a competition. Uh, I think all the other participants in last 2 years will agree that it's a platform that provides them disciplined thinking, provides them scrutiny from judges, experts, and make a very uh, unbiased and structured learning process. So to begin with, I'd like to invite the BOS president, Dr. Zaveri sir, to introduce the program and uh, talk about YROC 2025. Go ahead, sir.
Thank you very much, Ashok. At the outset, let me welcome each and every delegate for this BOS Rising Star competition. For Bombay Orthopedic Society, it is a matter of great pride that we are conducting this program to encourage and youngsters to excel in the field of orthopedics. This concept was brought forth by our past president, Dr. Sanjay Dhar, who is over here. And as Ashok mentioned, it has been a great success over the last 2 years. A number of participants have been there, and there has been a lot of excitement among residents to participate as well as wanting to win the awards associated with it. As president of the Bombay Orthopedic Society, I would like to also take this opportunity to invite all of you young delegates to YROC 2025. This year, YROC is going to be there from December 25th to December 28th. On December 25th, we've got 4 cadaver workshops: endoscopic spine, robotic hip and knee surgery, complex elbow surgery, and soft tissue management. I'm sure that all of you will gain tremendously from attending these workshops, but there are limited entries, and so register at the earliest. The actual YROC 2025 is from 26 to 28 December at the Westin Hotel in Mumbai. And aside from the normal programs that we have at YROC, the normal lectures, the case discussion sessions, the video sessions, what we've got specially for residents is a lot of different programs, including a session on studying abroad and opportunities abroad, where a number of faculty from England, from Australia, will tell you about how to go about to reaching out to go and do further studies or advanced studies in orthopedics or subspecialty in these countries. So please do join us for YROC. Other than this, there are a lot of other opportunities at YROC, such as master classes on master techniques, including how to do 3D printing in orthopedic surgeries, how to apply a negative pressure wound therapy, how to make antibiotic loaded cement nails and prosthesis. We also have a tech corridor where there are going to be robots used in orthopedics, augmented and virtual reality used in orthopedics, and artificial intelligence. We've got boot camps which will introduce you to some of the newer products that are available in the market in orthopedics and arthroplasty. This is going to be a never before YROC, and you certainly don't want to miss being a part of it. So please do register at the earliest. I wish each and every one of you the very best in this Rising Star competition. May the best win. I would like to thank OrthoTV, Ashok, Shyam, and Neeraj Bijlani, I would like to thank former President Sanjay Dhar, whose initiative this is and whose enthusiasm carries it further, and the two judges, Dr. Vidyanand Raut and Dr. Mohanty, who have agreed to spare their time to judge today's session. Best of luck to all of you. Thank you.
Thank you,
I would
sir.
like to pass it on to Dr. Sanjay Dhar to carry the proceedings further.
Yeah, thank you, Dr. Gautam. It's a pleasure, and we all look forward to a great Vairog. I'm sure, knowing you conducting it and designing it, it will be a fantastic event. So I take this opportunity to welcome all the contestants of this third edition of Rising Star. I'm very pleased with the response we have had this year. In fact, there were lots of participants who were asking for one chapter or other being included in one of the subspecialties. So I welcome you all, and I can assure you that it is going to be a fantastic event. And knowing the last 2 years, I can assure you that some of the presentations were really fantastic, better than much of our own faculty, who is established faculty. It's just that people like you need a little bit of push, and you need a center stage where you can express your abilities and speaking skills. So telling you about this contest, this is basically not only a speaking skill, it is how do you look at a subspecialty as your own, as you practice it. How do you want to project your own knowledge of that subject? And although we base it more on literature review, and because considering that you are just starting your careers, you have not seen your own personal cases, but how do you see the literature and how do you have assisted in such procedures? Your understanding, that is the whole key, and that is what judges will be looking at it. So play it very comfortably. Don't be stressed by the. I can assure you, all the winners who won last year have now become excellent speakers, and they are being invited for many of the conferences as a regular faculty. So I wish you all the best, and I hand it over back to Ashok to tell you about the scoring system and anything else we need to tell you about the contest. Thank you.
Thank you very much, sir. I'll invite Dr. Neeraj to mention the rules and regulations, and then we'll start with the first candidate. Neeraj, you're here?
Yes. Nice.
Yeah.
Neeraj can
Yes.
introduce judges also.
So this will be now every speaker will get a 6-minute presentation. So he will be judged on mainly the following points. It will be this presentation skills, the content of the presentation, structure and organization of the presentation, and how he has answered any questions, or if anything he has used very well in his presentation, we can give him some bonus marks. This is for the judges. So see to it that you finish your presentation in less than 6 minutes and do not exceed your presentation. With this, I hand over to Ashok to conduct the session further ahead.
Thank you very much, Neeraj. Would you like to introduce the judges also today?
Yes. So we have with us two eminent judges, Dr. Subhranshu Mohanty. He is the past president of the Bombay Orthopaedic Society and a very senior arthroplasty surgeon. And we are delighted to have him with us. We also have with us Dr. Vidyanand Raut. He is also an exclusive arthroplasty surgeon from the western suburbs of Mumbai, and also a Bombay Orthopaedic Society Executive Council member. So with this, I invite both the judges, and we have given you the mark sheet. So kindly give them marks accordingly. And with that, Ashok, please invite the first speaker.
Thanks, Neeraj. I'd like to invite the first speaker, Dr. Anand K Gupta. Dr. Anand, please share your slides and you can start your presentation.
Keep your video on all the time when you're doing the presentation and
He has
Q&A.
made a query that it was said 7 minutes. Ashok?
Yes.
Somebody has written query that it was 7 minutes initially mentioned, now 6 minutes. So we can
Okay,
keep
I'll check.
7 plus 3.
Okay, fine, sir.
Okay, we will keep it 7+3, no problem.
Am I audible, sir?
Yeah,
Yes.
Is my screen visible, sir?
yeah, go ahead.
So, wait. Sorry. Now my screen visible, sir?
Yeah.
Yeah, okay. So, thank you for giving me this opportunity. My name is Dr. Anand K Gupta, and my topic of discussion for today is cementless primary total knee arthroplasty in 2025. So, and the objectives of this talk would be to understand the current prevalence of uses of cementless total knee arthroplasty in 2025, and what are the indications and early failure with this technique. So this is a purely PubMed-based review study based on meta-analysis and randomized control trials of the last 5 years, and most of the studies are based on the international joint registries. So to understand the global trend of uses of cementless total knee arthroplasty, we will focus few studies based on the international joint registries. So this study by Log et al., which was published in the month of May this year, has quoted 7 countries and their registries from 2012 to 2022, including Australia, US, and 5 European countries. You can see the European countries, there is no change in trend in the uses of cemented total knee arthroplasty, but the US and Australia is showing decrease in trend of the uses of cemented arthroplasty. Whereas for the cementless, the US and Australia, there is an increase in trend in the uses of the technique, whereas the European countries are not showing any change in the trend. A similar study, which was published 1 month back, you have utilized the registry from Canada and New Zealand and also, where they have shown there is an overall average increase of 8.3% in users of cementless fixation in primary total knee arthroplasty over the past decade. So with this available joint registry data, we can see there is a rise or resurgence in the trend of usage of cementless total knee arthroplasty, and the reason behind it are mainly the improved survivorship of the cementless TKA due to the improved implant design, the acceptable midterm outcomes with this new implants, increase in the patient demand, and the more number of the younger age group patients are getting operated. And yes, there is no cement-related complications with the cementless TKA. So, what are the survivorship of the cementless TKA in 2025? So, as per Kaplan-Meier survival analysis, currently the cementless TKA is showing in many past studies comparable and better outcome as compared to the cemented TKA. So the main reason behind the improved survivorship is improvement in the implant design. So from the early 1970s to 80s, the cementless design have improved from dual pegs to the spike and keel construct. And now with the further improvement in the new implants, where you can see the use of plasma spray technique and sintered chromium cobalt based technique, use of bioactive surfaces like hydroxyapatite, periapatite, has increased the number of pores and increased the osteointegration of this implant with the bone. So there is a overall increase in the survivorship of the implant. So the earlier studies, which were published from 2020 to 25, were showing the comparable survivorship of the cementless TKA as compared to the hybrid or fully cemented TKA. The other study which have shown the survivorship or the outcomes at the midterm and the early outcomes are comparable with the cemented and hybrid. Whereas few studies which is published this year have shown now even the cementless implants are showing better results than the cemented one, and their survivorship are better, and their functional outcomes are also better. Regarding the indications of the cementless TKA, the earlier thought that young and active patients and the good bone quality were considered as indications, and the old age or osteoporosis were considered as the contraindications. But if we see the current literature, there are many studies which are showing that even with the age more than 70 or 75, the cementless TKA are giving good results, and the survivorship of the implant is very high. compared to the cemented, compared to the earlier thought now. And with regard to the bone density, now few papers are also showing that osteoporosis cannot be considered as a absolute contraindications, and use of the pharmaceutical adjunct, with the use of pharmaceutical adjunct, we can increase the survivorship of the cementless total knee arthroplasty in these patients. Regarding early failures related to the cementless total knee arthroplasty, the periprosthetic fractures and the early component migration were the main reason behind the early failure. But with the improved implant design, we can see the incidence of the periprosthetic fracture has become very comparable with the cemented one, where 1.2 is related to the cemented and 1.4% is with the cementless implants. And there is no statistical significant difference between both the techniques. And even if there is a difference, there is no long-term difference in the outcome of both the cemented and cementless total knee arthroplasties. So regarding the component migration problem in this new designs, they have introduced a new concept called interference fit. So with the improved technique, there is high interference fit, which is leading to the increase in primary stability of the implant, and which is also giving the long-term stability. So what are the take-home messages? So surely in the current scenario, there is a rise in or resurgence in the uses of the total knee arthroplasty or cementless type, with improved survivorship in the midterm and early outcomes, early follow-ups. And now even the younger and older age groups can be considered as a candidate for the surgery. Bone quality is still a questionable point, but yes, it can be used in all the types of bone quality. And the early failures of component migration can be dealt with the new implant designs. But yes, periprosthetic fracture are still a concern for the technique. And the limitations of this study was the lack of literature among the long-term results, and uniformity of the joint registries, and unavailability of data on the Indian population. Thank you.
Thank you very much. I think you finished on time. So let's invite questions from our judges. Mohanty sir.
Yeah. So good evening, Anand.
Thank you, sir. Good evening, sir.
Nice literature review about cementless hip, which is the burning topic nowadays in arthroplasty. Have you evaluated the patellar component that in cementless hip? What is the patella? Patella is cemented, or you leave the patella like that, or any take on the uncemented metal back patella which can be used? You didn't mention anything about patellar component.
Yes, sir. Because of the possibility of time, I didn't mention it, sir. So the previously with the cementless TK, they were less. They are the literature shows they did not used to replace the patella. Now with the improved techniques, the incidence of patelloplasty has also increased with the cementless TK. So
So it is cemented patella or uncemented patella?
People have used both the cemented patella. So I have not seen in my practice, but the literature shows that in past studies.
Okay. Have you gone through the literature about the etiological, diagnosis in these cases? Whether have they used in rheumatoid arthritis, post-traumatic arthritis, or these are only primary osteoarthritis? See, primary osteoarthritis, okay, the results are good. What about
Yes,
rheumatoids and post-traumatic arthritis and other conditions?
I could not found any recent study based on the rheumatoid arthritis, and so my focus was only on the available data on the recent years regarding the survivorship with implant. I did not see any study based on in inflammatory or post-traumatic arthritis, sir.
Okay. And you mentioned about BMD.
Yes,
Now, can you tell me, suppose you are doing a cementless total knee implant, would you do BMD in every patient pre-operatively, or you not do BMD? It's not required.
So wherever in my physical examination, if I see the patient is the shin of the patient, on examination, the shin bone is tender, and patient is complaining of vague pain while walking on the leg, on overall on the body. Then and the X-rays also show the signs of osteoporosis. Then we go for a BMD in some cases, but it's not a routine practice for us to do BMD for each and every patient undergoing total knee arthroplasty.
Thank you.
Did you,
Thank you.
sorry, did you review any literature on that BMD? Is there any basic minimum BMD that?
He showed one BMD. One slide was there.
One
Okay.
slide, sir.
Okay, Anand, nice presentation.
Yes, sir. Thank you, sir.
In a nutshell, can you give 3 or 4 bullet points why you feel cementless fixation is better than a conventional cemented fixation?
So the first part is good. If you achieve good osteointegration, the longevity implant or the durability of implant is higher as compared to the cemented, because cement is eventually going to fail, and the revisions in the cementless implant are very easy to do as compared to the cemented. And the current literature shows the osteoaseptic loosening has decreased in newer design cemented TK. So the longevity of implant, the easy revisions, and it can be used for any age group right now.
Okay.
Okay, thanks a lot.
Thank you. Thank you, Anand.
Thank you,
Thanks
sir.
a lot, Anand.
Thank you, sir.
I'll invite the next candidate, Dr. Dhruv Shah, to start his presentation.
Okay, so can you see my screen now, sir?
Yeah, we can see your screen, and his 7 minutes are starting now. Go ahead.
Good, sir. Okay, good evening, sir. Thank you everyone for this opportunity to present today. My topic is what is making total knee arthroplasty patients unhappy in 2025. So we perform nearly 300,000 total knees annually in India. The US, with 1/4 of our population, performs nearly 1 million annually. Historically, unsatisfied and unhappy patients were approximately 20 to 34% of all total knee arthroplasties. So are roughly 60,000 patients a year undergoing total knee in India unhappy? With advancing technologies, better implant designs, pain management, and strategies, can we accept 20% patients not being satisfied? So are we doing a good job? Most current studies measure outcomes of total knee from a surgeon's perspective regarding implant survivorship, range of movement, and radiographic alignment. Unfortunately, total knee cannot be deemed successful from a surgeon's perspective, but fails to deliver patient satisfaction. Harris et al. Concluded that they reported a discordance between patient satisfaction and surgeon satisfaction. So this can be a normal slide when there's a surgeon who's saying all my patients are happy, but all the patients really are not. So aim of this review is re-examine the current rate of patient dissatisfaction and identify predictable and modifiable factors causing patient dissatisfaction. So the methodology was through an electronic database. We reviewed the last 10 years of papers and selected studies with higher citation indexes with systematic reviews, meta-analysis, registry data, and trials. So how satisfied are our patients? Byrne et al. Confirmed 19% patients were unsatisfied following a total knee arthroplasty. This data was backed by Dunbar et al. From the Swedish registry, and they concluded that 17% patients were not satisfied. Gunaratne et al. In 2017 still reported a 20% dissatisfaction rate. This is concerning. So should we heave a sigh of relief? Recent reviews showed the dissatisfaction rates are decreasing on an average of 10 to 15%. DeFrance et al. In 2023 concluded dissatisfaction rates of 13 to 14%. On excluding post-operative complications like infection and fractures, the rate fell to 7.3%. Parvizi et al. Concluded 11% patients had dissatisfaction and inability to perform daily activities, and 9% patients were dissatisfied with their pain relief. So can we do better? According to Kevin Stone, our job is not just to fix a joint, but leave a patient happier when he leaves the clinic. So these are some of the researches which we used to identify the factors leading to dissatisfaction. The first was the socioeconomic factors. The ones which were associated with higher rates of dissatisfaction were lower income, lower education level, patients who were living alone, female gender, introverted personality. There's still no consensus on age, with some papers saying that higher age and lower age can both lead to dissatisfaction. So preoperative factors, the increased dissatisfaction rates, the most common one for factor for dissatisfaction is mild osteoarthritic levels undergoing total knee arthroplasty. Schnur et al. Said that in KL grade 3 patients, there's a 2.5 times higher dissatisfaction, and KL grade 2 have a 2.9 times higher dissatisfaction. Anxiety, depression tendency, and pain catastrophizing has up to 6-fold increase. AIC grade with more than 2, along with obstructive sleep apnea, back pain, and these show that after the back treatment, the TK satisfaction also goes up. Comorbidities and disabilities. There is again no consensus on the severity of the initial arthropathy. Post-operative factors, decreased satisfaction rates are obviously seen in complications, including infection, wound dehiscence, stiffness and fractures, persistent knee pain, decreased post-operative range of movement, increased length of stay in the hospital, poor physical health, patients who are apprehensive regarding the surgery beforehand, and unmet expectations. This is where the main question comes: patient expectations, single most important predictable and modifiable factor. Maniar et al. Showed that patients were overly optimistic about total knee arthroplasty with respect to their time to full recovery, painlessness, and ability to perform activities. This led to the EXPECT trial, expectation modification pre-op. So it was an RCT performed from the Eindhoven group in Netherlands. They had an intervention group having patient education and realistic expectation module, and control group having only patient education. The expectation scores were lower pre-op in the intervention group, and at 12 months post-operatively, the satisfaction and fulfillment were higher and statistically significant in the intervention group with the realistic expectation module. So other factors which we see every day, is tourniquet leading to satisfaction? No, no effect of tourniquet. The different implant designs, PS, CR, MS, nope, none of them affect patient satisfaction. Sutures or staples, no cosmetic outcome, no patient satisfaction changes with respect to them. CPAC alignment, no, according to RCTs, those also do not change any patient satisfaction. Robotics, use of robotics are conventional. They've been proven not to show any difference in patient satisfaction. And the component positioning, prosthetic alignment does not change irrespective of whatever alignment pattern you use, and does not change our satisfaction. So how will I change my practice today? I would have a stricter selection criteria, avoid extending indications, KL grade 2, 3 do not need a total knee. Expectation modification, providing additional leaflet modules for all patients likely to undergo total knee so the patients know what they're getting. Undersell and over deliver. Always undersell a total knee replacement. The patient should request and buy it from yourself. Employ a trained professional counselor throughout all stages of the patient's journey, which was also referenced in this article, which was done on an Indian patient group, in which they proved that empathy and engagement and education through a trained counselor who is specific towards the total knee improves satisfaction rates of the patient post total knee. Communication is the key. So this is the module which is created from the Netherlands group, given to each and every patient who is expectant for a total knee replacement, and gives them what they should actually be expecting from their total knee. So in conclusion, some knees look good but look bad but feel good. The challenge for us as surgeons are the knees which look good but feel bad. The unhappy knee and patient need to be heard. Individualize the treatment and address the emotional state. Always manage the expectations of the patient pre-operatively. 10% sounds like a small percentage, but in the coming few years, this will still mean lakhs of patients every year. These are my references, and I thank you. This is just a QR code for the expectation module from the EXPECT trial if anyone wants to use it. Thank you.
Thanks, Dhruv. It was good presentation. I'll
Thank you, sir.
invite our judges for questions. Mohanty, sir.
Yeah, Dhruv, excellent review of literature about the patient satisfaction, which is very
Thank you, sir.
important. Now, can you tell me how do you define what is dissatisfaction?
Yes, so that is currently the biggest question. How do you define satisfaction? Because most of our scales right now are according to Likert scale, and they only have 5 questions, and most of the people are defined between satisfied to very dissatisfied. And the last 2 ones, which are after neutral, so not dissatisfied or extremely dissatisfied, they currently come under dissatisfaction, which according to definition from our perspective is other patients who are not getting what they expected from their total knee arthroplasty. They might be better functionally, they might have better Oxford knee scores, they might have better quality of life, but they themselves are not that satisfied with what they were expecting pre-op.
No, those factors, how do you define this patient is dissatisfied? Only patient tells I am not happy about it. Is that the way to assess dissatisfaction, or there is objective assessment of dissatisfaction? Means some patients are not happy with range of movement. Some patients are,
Yes.
still painful. Some patients, these are the things. Is there any objective assessment that you tell, okay, this score is from more than this, then it is dissatisfied?
So there is a score which is the Knee Society score, which came in 2011 from the Scuderi group, and they have an objective pattern which has 40 points, which is given for the satisfaction part, and 15 points, which is given for the expectations part, if they are met or if they're not been met. So the new Knee Society score, which came in 2011, does allow us to grade the satisfaction from the patient's perspective and from the surgeon's perspective.
Yeah. So next, number two, in India, one of the important factors of dissatisfaction is financial aspect.
Yes, sir.
If the cost increases from whatever has been told them pre-operatively, then patients are dissatisfied.
Yes,
So
sir.
you didn't mention anything about financial aspect. Is there any literature to show that
So through the
most
literature
of the
review,
private hospitals, their cost increases? They're never whatever has been told beforehand.
yes, sir. So through the literature review, I have not found anyone which is coming out with the factor of financial going up or down. But I agree that this would be a very important factor for us and the developing countries to look into. And this will obviously be a huge thing with the current changes in insurance programs and everything, especially with the private hospitals. But as of now, there's no review specifically linking financial expectations and how much of the budget is exceeded with patient satisfaction.
And my third question is how to improve the satisfaction level after you evaluate that this patient is dissatisfied, and when? When do you brand this is dissatisfied? Does 6 weeks, 3 months? Is there a timeline, 1 year?
So the patients can come and tell us that they're dissatisfied at day one, and they can come at 1 year as well. But most of the scorings which we see are marked at 1 year and a minimum of 3 months. And the way to do it is obviously you speak to the patient, let them know, you have to give them empathy, you have to hear them out, because most of these patients have some amount of mental health component along with it, which is causing the dissatisfaction. So listen to them, tell them that this is normal, and you have to tell them that this is not just happening to you, it has happened to everyone, and within a year or within 2 years they do tend to get better.
Okay, thank you.
Okay.
Over to Vidya.
Excellent presentation, Dhruv. I have one question.
Thank you, sir.
You
Yes, sir.
mentioned that unmet expectations is one of the
Yes, sir.
prime reasons why the patients are not happy. So
Yes,
I'm
sir.
asking a practical question. If a patient comes to you, post-op X-ray, you are happy with your own performance, alignment is good, stability is good, maybe you have used a robot and you are very happy.
Yes,
But
sir.
we do get patients who are not happy, despite whatever you tell them, they are not
Absolutely.
happy. They are not happy. They have some stiffness or some anterior pain or some generalized weight pain or a limb.
Yes.
So how do you counsel them? What do you tell them? Do you tell them go away, take painkillers and go away, or how do you approach this patient?
No, so the first thing which when they come out and say this to you, you have to not go out and say that, okay, no, the X-ray is normal, everything is right. No, you have to listen to them, because whatever they say is what they're feeling. And at the end of the day, that is more important. Whatever may be the X-ray, doesn't matter if the patient is not happy. It's not going to be a success for them or us anyway. So you explain to them that this is how we are going to be. There's now an increased use of psychological counselors who are involved pre-op and post-operatively, who help them and guide them to it. They need someone to talk to. So that is one thing which helps. The other thing which can help them is you also have to be very clear and start looking for things which we may have missed, which is normally other joint pains, which is spine, ankle, hip. We have to look at those, rule out any kind of subtle infections, rule out any kind of mental health disorders, and then still keep on counseling them. The moment you start turning them away, it is going to get worse and worse. But if the patients still stick to you and you keep on counseling them, they should be fine. The patient satisfaction rates are generally tend to go up after the 6-month mark.
Okay. And my second question is, in your pre-op assessment of the patient, when you counsel the patient,
Yes.
how much do you stress on the possible complications We cannot give a whole list of complications, but what
Absolutely.
sort of discussion do you have with the patient?
So at least we have to explain to the patient that yes, TKR is a very successful surgery in general, but we do explain to them that yes, 1% to 5% patients can have some kind of complications. And thankfully now most of the patients are quite educated to the level of infection and maybe fractures. But you do have to give them, at least you have to tell them that there is a risk of 1% to 2%, any kind of complication, which includes infection, subtle infection, or scar gaping. But it should not be the most part of your consultation because it unnecessarily will cause mental stress into the patient's head before the surgery. And that is not a good thing overall. Even if there's no complication post surgery, the patient is still going to be quite apprehensive before the surgery itself.
Okay, thanks, Dhruv.
Thank you, sir.
Dhar sir, you have any questions? So,
I just have one question. In your study, Dhruv, did you find anything that, like in spine, we used to do Minnesota score to have a preoperative assessment of their mental
Yes, sir.
status? Is in knee arthroplasty anything that preoperatively we have certain studies which show that these people are bound to get unhappy? Is there any study which you did, or any preoperative prehab or physiotherapy would make them better post-operatively? Is there any study like that?
So there's one study which was done by Dhruv et al., and they had shown that they used to assess the pain and the pre-op mental state with the SF-12 score, and they used to correlate that with the risk of, okay, this patient might have a chance of having a dissatisfaction. The other way is using the Oxford Knee Score, which has the Knee Society Score, which has a patient satisfaction component, which is done pre-operatively, and these are used as predictors for this patient that they will do well or they may not do well.
Okay, that's all.
okay.
Thanks, sir.
Uh, Thanks, Dhruv.
Thank you,
Sir,
sir.
invite the next candidate, Dr. Abhilash, to share his presentation.
Yes, sir. So is my screen visible?
Yeah, his screen is visible.
Yes. I'll start, sir.
Yeah, play the presentation.
Yes. Good
Okay, go
evening,
ahead.
respected judges and faculty. I am Dr. Abhilash Srivastava. My topic for today is to compare restricted or functional alignment with mechanical alignment with the recent studies. So TKR basically aims to relieve pain and restore functions in arthritic knees. So our objective here is to compare restricted or functional with the mechanical alignment using recent evidence. My sources are PubMed, Google, RCPs, meta-analysis, systemic reviews, and studies with higher citation index. So this is the evolution of alignments in TKR in the past years. But why do we need such different alignments? Because different people have different alignments leading to different adventures. So what basically is mechanical alignment? As given by Professor Insal, mechanical alignment tells us to cut the distal femur and the proximal tibial angle perpendicular to the mechanical axes to restore neutral limb alignment with components perpendicular to the femoral and tibial axis to ensure equal load distribution and symmetrical gaps. But why this debate of different alignments? Mechanical alignment has come with its own set of problems, with up to 20% of patients annually who have non-satisfactory outcomes proven time and again with multiple research. One of the papers by Dr. Robert Vaughan presented in year 2017, where he said that up to 20% of the patients annually TKR are not satisfied with the outcome. This is a paper by Professor Insal, where he reported that even with meticulous alignment, patients are not satisfied with, we cannot get complete alignment in TKR. Another study by Professor Revere described that there are some problems with the intrinsic technical limitations in mechanical alignment, like the patellofemoral mechanism related problems like overstuffing of lateral extensor mechanism. Another study by Dr. Becker showed that there are 10 flaws of systemic mechanical alignment in TKR. Sorry. Okay. Hello.
Can you please put the play?
Sorry.
Make it full screen.
Yes, sir. So Dr. Becker said that we assume that there is neutral limb alignment for all. We oversimplify complex 3D knee geometry. We assume that the disease compartment is tight and hence requires release, and the mediolateral flexion and extension gap should be isometrical. So there's a paper by Dr. Bellmans where he said that are we all aligned in neutral? So he said that an important fraction of the normal population has a natural alignment of 3-degree varus or more, which means approximately 32% of the population is in the varus axis of HK. There's a famous classification of knee phenotypes by Professor Magdesai, where he said that there are 9 different phenotypes for different knees, out of which type 1, 2, and 5 are most common. There's a similar study of CPAC classification in Indian population by Dr. Vinay Samant and Dr. Mohan Desai, where he said that the most common type is type 1, followed by type 2, and then type 4. Then came the concept of kinematic alignment, which recreated patients' native pre-arthritic knee using 3 rotational axes with minimal ligament releases. The problem was that it may yield outlier limb alignment in severe deformities. Then so came the concept of restricted kinematic alignment, which followed kinematic alignment but within safe mechanical limits. It restored native joint line and prevented excessive malalignment. It used mainly navigation or robotics. Then further came the concept of functional alignment, which restored patient-specific alignment within safe mechanical limits and uses robotic or navigation system. It provided a natural feeling with fewer soft tissue releases. So came the concept of restricted functional alignment, which applied the same functional alignment principle, but with safe mechanical limits. It restored the native anatomy and balance using mechanical safety, which reduced soft tissue releases. Now let us look at some evidences to comment on the differences between restricted or functional with mechanical alignment. So this is a paper by Dr. Simon presented in 2025, where he did an RCT for mechanical versus functional alignment in 244 knees. And he stated that functional alignment required fewer soft tissue releases, and it offered better knee injury, osteoarthritis, and output score symptoms and quality of life, higher patient satisfaction, and lesser soft tissue disruption. Another paper by Dr. Gavin Clark in 2023, where he stated that functional alignment achieves a more balanced TKR than either mechanical or kinematic alignment prior to soft tissue release in 300 knees. And he stated that the functional alignment provides more consistent gap balance than both mechanical or kinematic. And kinematic alignment-based functional alignment preserves joint and obliquity and native soft tissue release within soft tissue limits and without ligament release. There's a famous paper by Dr. Gurva Reddy published in 2023, where he compared mechanical alignment and functional alignment in 72 patients undergoing simultaneous bilateral robotic TKR. And he said that the functional alignment achieved significantly higher pre-balance and a fewer soft tissue release. The VAS pain was markedly low in functional alignment, and it produced better medial compartment knee balance. Another paper by Dr. Meena Morkos published in 2024, where they did a long-term follow-up of 104 knees undergoing restricted kinematic alignment, and stated that it showed excellent 10-year outcomes with higher satisfaction, function, and implant durability. There's a famous paper published in 2025 from Rajvati Hospital, Thailand, where they compared bilateral robotic TKR in 30 patients using mechanical alignment and functional alignment, and stated that functional alignment yields similar alignment, better joint line orientation, and lesser soft tissue release than mechanical alignment, and higher early function scores and satisfaction, especially in virus or CPAC type 1 knees. A study done by Dr. Mishu Jeffrey in 2024, where he compared clinical outcomes of functional alignment and mechanical alignment in 64 patients. And he commented that functional alignment with robotics had a better short-term functions, better forgotten and joint score, OKS, and knee severity score. The paper by Dr. Wong Taoji presented in 2025, where he compared early clinical outcome of functional alignment with mechanical alignment in robotic TKR. And he concluded that robotic functional alignment had less soft tissue release, lower pain, and better early function versus mechanical alignment, though the long-term outcomes were still pending. So to conclude, functional alignment restores native knee mechanics and achieves superior soft tissue balance compared to mechanical alignment. It provides better flexion extension gap balance with fewer releases, and early robotic studies showed improved reproducibility. Long-term data of restricted kinematic alignment demonstrated excellent implant survival and sustained function. So for future, we have to move forward towards individualized phenotype-based alignment to optimize patient satisfaction and longevity. My take-home message would be that the alignment philosophy is continuously evolving from mechanical neutrality to functional individuality. It respects patient's anatomy and gives a natural knee kinematics. It delivers smoother flexion extension and stability, and makes it more accurate, reproducible, and safe. With fewer release, there's faster recovery and happier patient. The Personalized alignment is the future. Long-term follow-up will define how it shapes next generation knee or arthroplasty outcomes. These were my references. Thank you.
Thank you, Abhilash. I'll invite our judges for question and answers. Mohanty, sir.
Abhilash,
Yes, sir.
you have taken the most controversial topic,
Yes,
but
sir.
let me ask you that what is your personal philosophy? What
So,
alignment you will do?
so I've seen in the
Could
center
you
where
stop
I
sharing the screen?
yes, sir.
Can the admin do the stop sharing the screen? Yeah.
Yes.
What is your personal philosophy?
So in the center where I work, I've seen both mechanical, earlier seen as mechanical alignment, and currently we are doing robotics alignment with functional, robotic TPR with functional alignment. And I've seen patients with functional, they have lesser pain, they have early ROMs, and I've seen better results with functional alignment compared to mechanical alignment. So I would personally prefer functional alignment
Can you do?
if the robotic is available.
Okay. If the robot is not available, then can you do a kinematic alignment or a functional alignment? Is it
Yes,
possible to do?
yes, sir, it is possible to do it without a robot. Also, a robot makes it more precise with more cuts. We can also go for a restricted kinematic alignment if the robot is not available.
So how much, suppose you are doing manually, then how much, virus you can give to the tibial component?
So we can go for till plus or minus 3 degrees of varus or valgus, and we aim to achieve up to 5 degrees of hip knee ankle.
See, naked eye cannot judge until
Yes,
3
sir.
to 5 degrees. So it is difficult to do without robot that
Yes, sir.
kinematic
It is
alignment.
difficult. Yes.
Now, what is adjusted mechanical alignment? You didn't
So
mention about that.
adjusted mechanical alignment, this came after the mechanical alignment. I found a paper related to the adjusted mechanical alignment versus functional alignment, where they did a comparative study of 119 patients. And they also found that the adjusted mechanical functional alignment outcomes had a better result compared to the adjusted mechanical alignment patients. They did a comparative study of bilateral knees, and they performed each in each knee, and they said that the functional alignment need had a better.
What is the difference between an anatomical alignment and mechanical alignment? What do you understand by anatomical alignment?
Some in mechanical alignment, they aim to get the distal femur and the proximal tibia at an angle 90 degree to the mechanical axis in mechanical alignment. While in anatomical alignment, the philosophy is to recreate the natural oblique joint line of a normal knee rather than forcing a neutral mechanical axis. It aligns the femoral and tibia to mimic the physiological valgus of the femur and slide approximately 5 to 6 degrees and slight varus of tibia, sir, 3 degrees. And overall, the alignment remains around 3 degrees of valgus.
Thank you.
Yes, thank you, sir.
No questions.
Sir. Yeah.
No questions, to
Dhar, sir, you have any questions?
No question.
Okay. Thank you, Abhilash. I'll invite
so
our
much, sir.
next contestant, Dr. Adit, to start sharing his presentation. We can see your slides.
Yes.
You can start.
Yeah. Good evening, everyone. I would like to thank Bombay Orthopaedic Society and BIROC for giving me the opportunity to present today. My topic today is oral anticoagulants for VTE prophylaxis after primary TKA.
Adit, check your audio. Is it very low?
Let me just check again. No, can you hear me now? Hello?
Is the audio clear for everyone? Go ahead, Adit.
Yeah.
Yeah, so my topic today is oral anticoagulants for VTE prophylaxis after primary TKA and THA, efficacy, bleeding, and cause signals in contemporary studies. There has been a recent surge in literature regarding aspirin usage in hip and knee arthroplasty. And this may explain the increasing trend of utilizing aspirin as a primary prophylaxis for DVT in knee arthroplasty recently. However, if you look at this analysis of clinical guidelines, they concluded that guidelines were inconsistent in their recommendations regarding aspirin as first-line therapy for VTE prophylaxis in arthroplasty patients. And they recommended adequately powered randomized controlled trials for further research. And so our aim today is to provide a narrative review of literature comparing aspirin with oral anticoagulants for VTE prophylaxis in primary TKA and THA, with a focus on efficacy and bleeding as well as cause signals. We retrospectively reviewed multiple databases and references of relevant articles. We included retrospective, prospective studies as well as systematic reviews and meta-analysis. We only included articles directly comparing aspirin and oral anticoagulants or DOACs, and we excluded articles before 2015 and those that were not in English. I'm going to present the results for efficacy and bleeding separately, followed by cause signals. So looking at the retrospective studies, majority of the studies had a sample size less than 1,000, with a few studies having a larger sample size. Comparing aspirin versus DOACs, for majority of the studies, there was no difference in DVT or PE rates as well as major bleeding risk. 3 studies had an increased DVT and PE risk with aspirin, whereas 2 studies had an increased major bleeding risk with DOACs. Coming to the RCTs, majority of the studies had a sample size which was less than 200, with only 1 study having a sample size of more than 3,400. Some studies had THA alone, some studies had TKA alone, while some had both, which may have affected the results. As we all know, DVT and PE rates are higher in TKA patients. Lastly, almost all studies excluded patients for high risk of VTE or PE after surgery. Looking at the dosage of aspirin used, there was a wide range from 75 milligram to 300 milligram per day over a span of 9 days to 6 weeks. 3 of the studies used a low molecular weight heparin or rivaroxaban prior to starting aspirin. In terms of DOAC, rivaroxaban was the most commonly studied drug, with a 10 milligram daily dose in all and a range from 9 days to up to 5 weeks. Looking at the results, the rates of DVT and PE were comparable between the 2 groups. Interestingly, in 2 studies, there was no incidence of DVT and PE, which may suggest underpowered studies. Looking at the total bleeding risk, 2 studies had a higher rate with rivaroxaban, whereas the major bleeding risk was comparable in all between the 2 groups. Looking at meta-analysis, this meta-analysis from 2021, which included both prospective as well as randomized controlled trials and retrospective studies, found a higher DVT, PE, and bleeding rate in the aspirin group. This meta-analysis of only RCTs found a higher VTE rate with aspirin group. Although the total bleeding and minor bleeding was higher in the DOAC group, the major bleeding was comparable between the 2 groups. Looking at this meta-analysis that included RCTs only from 2017 to 2023, they had 3,967 patients overall. Please remember this number. The overall DVT, PE, and bleeding rate was comparable between the 2 groups. This network meta-analysis of patients undergoing only elective total hip replacement ranked different prophylaxis, and they found that the rivaroxaban had the highest rank for DVT prophylaxis. For PE and major bleeding, the highest rank was for low molecular weight heparin, followed by aspirin. But they also concluded that rivaroxaban may be safer than previously thought when considered for major bleeding. Coming to the cost, when looking at the costs of primary treatment, differential PJI rates, as well as high costs of management, this study from JOA found that the factor 10A inhibitors were less cost effective. This study from the English National Health Service looked at elective THR and found low molecular weight heparin followed by aspirin for 28 days to be most cost effective. And for elective TKR, interestingly, they found ankle foot pump exercises to be most cost effective, but they found that the results were highly variable, so they could not make any clinical inference from this. And if you did a simple cost research, Google search, I think there is no doubt that aspirin is definitely cheaper than any DOAC. But what does this all mean? There is so much of information. If you look at the current literature, the rates for DVT, PE, and major bleeding are comparable between aspirin and DOAC, but they are not superior with aspirin. Also, it is important to understand that most of the studies seem to be underpowered. There are differing doses of aspirin as well as duration. Multiple studies also used a low molecular weight heparin or a DOAC prior to aspirin, and all RCTs eliminated high-risk patients that are patients more likely to undergo VTE. Also, there is no doubt about aspirin being cheaper, but the cost effectiveness for VTE prophylaxis alone is unclear. So what does the future hold? This randomized control trial currently underway has a primary outcome looking at all-cause mortality and clinically confirmed VTE. Their estimated sample size is more than 6,000 patients in the aspirin group and more than 4,300 patients in the rivaroxaban group. This tells us that majority of the current studies may be underpowered to detect a difference. And lastly, the factor 11A inhibitors like milvexian may be the future for oral anticoagulation post-primary hip and knee arthroplasty. These are my references. I would like to thank you all for a patient hearing.
Thank you, Adit, for finishing in time. I invite our judges for questions. Mohanty, sir, you can go ahead.
Adit, excellent review of the literature about this oral anticoagulants. What is the mode of action of aspirin?
So it is antiplatelet. It is not a direct anticoagulant. It acts on the platelets.
So if the mode of action of aspirin and other oral coagulants is completely different. So how do you compare?
Yes, sir.
For this
They are completely different, but I think this was the topic, and this was also, I think, over time, the usage of aspirin for primary TK and THA for prophylaxis has only increased.
Sorry, I couldn't hear last
I think
part.
this was the topic that I was given, and also, sir, overall the usage of aspirin has only increased for DVT prophylaxis for primary hip and knee arthroplasty. Most of the literature so far compares aspirin to low molecular weight heparin and DOACs to low molecular weight heparin. But if you look at the literature comparing the two, there is very few studies that you can make a clinical inference from.
Have you reviewed any literature about comparing different doses of aspirin?
Yes, sir. There are studies looking at high dose versus low dose, and most studies have found that low dose is equivalent, if not superior.
See, low dose means what? It is
So
75,
different
150, it is 81. And what is high dose? Where is the cutoff point for low dose and high dose aspirin?
So I think that it is not a very clear demarcation. It also depends on which country you are in. The dosage range that has been reported is from 75 to 325 milligrams, depending on where you are. 75 milligram in India, in the USA and Canada, you would get minimum of 81 milligrams. And so that is the minimum dose that is considered low dose. Anything over 150 milligram daily is considered high dose.
And how long do you give for THR, how for TKR, how for revision?
Yes.
How
So
long?
I think, again, the guidelines vary, which is what I was trying to show in the study, that there was a big range. Some gave only for 9 to 10 days, whereas others gave up to 6 weeks. I think it is clear for at least 14 days for total knees, and for total hips a little longer for about 3 to 4 weeks. With DOACs, you can have your prophylactic period shorter, so 2 to 3 weeks. With aspirin, it may need to be longer.
Is there any cases that you will prefer warfarin now at
There
present?
are
in
very few
2025?
cases which would also include someone who's already on warfarin, and anyone who has a contraindication to using either a DOAC or aspirin.
Okay. Okay, thank you. Vidya.
Can you hear me?
Yes, sir.
Okay, so Adit, great presentation. The incidence of a thromboembolic episode is highest in the first week or the first 10 days. Yet, most of the studies recommend that you give the prophylaxis for 4 to 5 weeks. Can you discuss about this point?
Yes, sir. So I think, yes, that is correct. The highest is in the first 15 days, but I think the risk is higher for the first 3 months compared to that afterwards. I think the guidelines and the recommendations are so varied that it is difficult to, everyone has their own way of doing it. I think the minimum everyone recommends is 14 days. And the maximum, as you said, has been recommended up to 6 weeks. I also think it has to do a little bit with the drug that you are using. With something more potent like a DOAC, 2 to 3 weeks might be enough. Whereas when you're using aspirin, they recommend it for a little longer.
So, which is your preferred drug of choice?
Currently, I'm using low molecular weight heparin for the first 3 to 4 days and then switch over to oral DOAC, rivaroxaban, for 3 weeks, for a total of 3 weeks post.
Yeah, Adit, great, thanks.
Dhar, sir, you have any questions?
Just wanted to tell him, did you see any literature regarding a combination therapies like pneumatic pumps plus aspirin or pneumatic pumps filled DOS or anything like that?
Yes, sir. So, sir, most of these studies which compared aspirin to DOAC either used pneumatic pumps in both the groups or did not use them. I only included studies which had a direct comparison. But if you look at some of the network meta-analysis, there are some studies there which would say that only compression devices or mechanical prophylaxis alone can be as effective as aspirin or a DOAC.
So is it the current literature or
Yes,
anything?
sir, a few
This
years
you are
old,
mentioning
but
as a recent literature? Or?
but it is not level 1 evidence, and it was more retrospective. And only one study that I've come across that would say that mechanical prophylaxis alone is enough.
Okay, thank you.
Thanks, Adit.
Thank you, sir.
I'll invite the next presenter, Dr. Suyog, to share his presentation.
Good evening, everyone. Am I audible?
You're audible. Share your presentation. Yeah, we can see.
Good evening, everyone. At the outset, I would like to thank the Bombay Orthopaedic Society for providing this platform. I'm Dr. Suyog Wagh, and today I'll be talking about the utility of mobile and fixed bearing in total knee replacements. Taking a brief look at the history of total knees, in the 1900s, we had the ivory gluck knee. In the 55s, we had the hinge knee by the Waldiers. But towards the end of 1970s and 80s, we had condylar, modular, and cemented implants, which provided reliable outcome, excellent stability, and pain relief, making total knee a gold standard for advanced arthritis. However, this led to extending the surgical management to younger patients, which questions arose regarding issues with polyethylene wear and need for improved longevity, especially in settings requiring cross-leg sitting and squatting. These challenges led to the advent of mobile bearing, which allows controlled movement of the polyethylene over the tibial tray, as we can see in the video here, which reduces stress and wear at the bone implant interface, which mimics near normal knee kinematics, which directly translates into better load distribution, improved conformity and stability, and reduced polyethylene wear. Kinematic studies have also shown that the contact stresses are less in fixed bearings than in mobile bearings. Flipping the coin, because of rotation of the polyethylene, excessive rotation can cause to a spin out of the polyethylene, which is known as a spin out. Is a complication unique to the mobile bearing design. It's a radiograph showing the same. And also because of consistent movement of the polyethylene over the tibial tray, there can be issues with backside wear. So to see where we stand today, what I have done is scanned the electronic databases of the past decade and included systemic reviews, meta-analysis, and government registries. What we see in the registries is a stark difference in the usage of mobile bearing, which was approximately 90% in the USA and 70% in the Europe in around 2000s, has now significantly dropped to 5 to 15% throughout the world. However, there are certain studies which suggest that mobile bearing has advantages, such as this paper by Pes Brito, which suggests that patients with mobile bearing had less patellofemoral pain, better ability to use stairs, less walking pain, some improvement in functional scores, although non-significant, although certain studies have non-randomization and demographic imbalances. There are certain small meta-analysis which suggest that the functional score improves with mobile bearing. However, the clinical scores, range of motion, and WOMAC do not increase. The drawbacks of this such meta-analysis is that minimal number of studies are included with higher heterogeneity, and objective parameters such as wear and revisions is not compared. This is an award-winning paper by Dr. Vishal Hegde, which analyzed approximately 5 lakh cases in the American registry, which suggested that there is an increased all-cause revision with mobile bearing. However, there was no difference in infected revision rate, suggesting that the revisions in mobile bearing could be because of aseptic loosening, polyethylene wear, or spinouts, although the exact percentage of complications were not reported in this paper. Despite this, more than 95% survival was seen with both the designs at 10 years. The relative risk of revisions as reported in the Australian registry is 2.6, whereas it is a whopping 6 times in the Norwegian registry, suggesting that there are geographical differences which could be because of difference in surgical techniques. Coming to spinouts, the incidence of which was approximately 10% initially has now fallen to decimals. The initial causes were flexion instability and improper ligament balancing. Maybe those have been taken care of properly now. And along with that, advent of certain implants with anterior stoppers which prevent excessive rotation of the polyethylene also reduce the complication rates. This is a 14-year-old double-blinded study which suggests that the KSS, WOMAC, SF36 and satisfaction rates in mobile and fixed bearing is comparable. And there are many studies which suggest similar findings that both the implants are equal, although there are certain studies which say that mobile bearing has increased complications, although the difference is not significant. In the literature review by Dr. Kapila, it suggested that the mean ROM, KSS, OKS, 10-year survivorship, and aseptic loosening was comparable in both the designs. In fact, many meta-analysis and systematic reviews from throughout the world suggest that both the implants have similar outcomes and similar functionality, and we can see that there are innumerable papers throughout the world which suggest the similarity. In one of the most recent meta-analysis, which was comprehensively done by Dr. Ashraf, which compared 70 randomized controlled trials regarding this topic, it suggested that outcomes, OSS, KSS, pain relief, revisions, aseptic loosenings, and radiolucencies are equal in both the implant designs. So what we see that there are proponents of both the sides, with some studies suggesting mobile bearing has more complications, some saying there's better outcome, but truth lies somewhere in between, with majority of the studies saying there is no objective difference between the two designs when it comes to functionality and outcome. Coming to certain special conditions such as revision TKRs, use of stem extenders and fractures and malunions, the ideas such as rotational decoupling, ease of alignment, reduced polyethylene wear, and less torsional stretches, also availability of smaller size implants make the use of mobile bearing more appealing in these cases. However, there is no direct comparative randomized control trial, systemic review, or meta-analysis for the same. We can see that the use of total knee replacement with mobile bearing design in revisions has showed good outcome in midterm. In revision cases with improved cases, no complications such as pinouts, good functional outcome. However, long-term follow-up is not available in such cases, with maximum follow-up they have checked is up to 5 to 6 years. Also, in certain cases like distal femur malunion, the use of mobile bearing becomes more appealing, where slight malalignment can be tolerated because of movement of the bearing. And also in cases requiring isolated stem extenders of the femur, mobile bearing becomes a good option. Although these are rare, not rare, isolated case reports that have been published, but not comparative data is not available. So a take-home message is that one size fits all is not applicable in this case. There are certainly theoretical advantages of mobile bearing, but these have not been replicated in larger studies. It remains a reasonable option for revisions, extenders, and malunions, although direct comparative studies are not conducted yet. Finally, one has to individualize the choice of implant based on ligament balancing, surgeon experience, and training. These are my references, and thank you for the patient hearing.
Thank you very much, Dr. Suyog. I'll invite our judges for questions. Mohanty, sir.
So a good presentation. We
Yes,
have
sir.
done a good literature review about the mobile bearing and fixed bearing. My question is that whether you have found out that any cruciate retaining or cruciate substituting design of mobile bearing and fixed bearing. You didn't mention anything about that.
Yes, sir. I found that in the studies it was mentioned that although cruciate retaining is supposed to have better functionality with mobile bearing, but there was no difference that was found in the outcomes. They fared equally, like PS fixed bearing versus PS mobile bearing and CR mobile bearing versus CR fixed bearing fared the similar same results.
No, I'm asking about CR mobile bearing and PS mobile bearing.
So yes, we have seen that the literature suggests that the outcomes are same, although the risk of complications is higher with PS mobile bearing, sir.
Risk of complications are more with PS mobile
Yes,
bearing.
yes, sir.
So in CR, you will prefer to use a mobile bearing.
Sir, I will personally not prefer a mobile bearing, but the literature suggests that, sir, because fixed bearing and mobile bearing overall have similar outcomes. That's why I will not prefer mobile bearing in primary cases, sir.
Because in CR knee, there is no cam and post mechanism.
Yes.
So there is a possibility of spinning out is more because there is no restraint for that mobile bearing insert.
Yes, sir. But what was seen that the risk of spinouts was more before 2010. After 2010, the advent of Bunel Papa's implant, that has anterior stopper, the spinout risk has reduced. Buchel Papa's, yes. And since 2010, the risk of spinout has overall reduced. And in PS knee, the wear is more in the cam area. That's why the overall risk would be more in PS knees.
Now, when you will not use a mobile bearing knee?
Sir, in mobile bearing, I will not use if some ligament misbalancing is there, and if requirement of tibial stem extenders with bone loss is there, I will prefer using fixed bearings because of cost constraints also, sir.
Is the mobile bearing knee more expensive?
Sir, in tibial extenders with bone loss, use of mobile bearing will require use of augments that might increase the cost. That's why.
Not necessarily.
Okay.
Okay. And suppose there is a bone defect.
Yes.
And you need to use screws and cement built up. Will you use a mobile bearing or a fixed bearing?
Sir, I will use a fixed bearing, sir.
Okay. Over to be there, please.
So great presentation. My question is, if you are in a position where you have to use a higher constraint, like you are using a varus valgus constraint knee or even a hinge knee,
yes, sir.
How do you decide? Do you go for a mobile bearing or do you go for a fixed bearing? And what is your rationale?
Sir, in cases requiring higher constraints, I would prefer mobile bearing since the midterm data is good and theoretically it has advantages like less load is transmitted towards the polyethylene and towards the opposite side of the implant. Also, in case usually it is used in revision cases where anatomical landmarks are hampered. So some misalignment at the component level can be managed with the bearing, sir, because the bearing also rotates.
No, but the question is, if there is a misalignment of the component, it is at the fixation level. And the mobile bearing, the component, the poly rotates at a different level. So how is that beneficial? And moreover, mobile bearing technically is more difficult. So in a challenging situation, would you prefer mobile bearing or fixed bearing?
Sir, in revision cases, I would prefer mobile bearing because of the theoretical advantages, and I would stick to it till some conclusive evidence suggests that mobile and fixed bearing are similar, sir.
So you're saying there is no role of a fixed bearing TC3 like implant or a CCK like implant, is it?
There is, sir, but I would prefer a mobile bearing because there are no conclusive evidences suggesting that there are no comparative trials. That's why I find the idea of mobile bearing better in revision cases. That's why I will prefer it.
Okay, yeah, thanks.
Any questions there, sir? Dr. Dattatreya, you can share your presentation. Thank you, Suyog.
Thank you.
Dr. Dattatreya, you can share your presentation.
Yes, sir, I'm presenting, sir.
Still loading?
Yes, sir. It is taking some time.
Okay, you can start.
Sir, 1 minute, sir. So, can you hear me, sir?
Yeah, we can hear you. We can see your presentation. You can start.
Okay, sir. Good evening, respected judges, senior colleagues, and friends. I am Dr. Dattatreya SitaRam, and today I'll take you through a question that defines where the robotic arthroplasty stands in 2025. Has precision in alignment truly translated into better outcomes, or is robotic TK still a story of alignment without function? With emergence of technologies every decade, there is also a proportionate increase of adaptation of these technologies in the clinical practice. Our objective for this narrative review was simple yet critical: to systematically evaluate whether the alignment precision achieved with robotic total knee arthroplasty has led to measurable improvements in patient outcomes. We aim to distill clarity from growing body of evidence of meta-analysis and systematic reviews to understand in evidence-based terms what robotics has truly delivered. We conducted a structured PubMed search using the comprehensive Boolean string combining 3 major clusters: robotic TKA, alignment concepts, and clinical outcomes. From these 9 meta-analysis published between the last 10 years that were used to score 3 components, that is alignment in terms of HKA and clinical outcomes in terms of the pre-op and post-op prompts, that is WOMAC, OKS, KSS, FJS, and ROM, and overall conclusion. And each parameters are scored on a scale of +5 to -5, +5 being supported in the favor of robotics, -5 opposing the robotics, 0 being inconclusive about the robotic advantage. So in this study by Yu et al., clearly showed that robots has a clear advantage over the conventional technique to precisely restore the mechanical alignment in the form of hip knee ankle axis, and KSS, OMAC, and HSS showed no significant difference between robotic and the conventional techniques. So overall, the robot has advantage in the alignment, but questionable in the functional outcomes. Then in this study by Few et al., again showed a superiority of the restoration of the alignment, but again did not show superiority in the functional outcomes. Then in this study by Chen et al., so they have studied the survival analysis of the implants done with the help of robotics compared to the conventional technique, and they found superiority of the survival, but not statistically significant difference in comparison with the conventional techniques. And the functional outcome also, some scores showed improvement, some score did not show the improvement. Then Rianto et al. Showed superiority again with the mechanical restoration of the alignment, but again in their study they focused more on the radiological outcome and they did not show any parameters about the clinical outcomes. So overall, across all these 9 studies, there is clear-cut superiority of the evidence showing that robots have achieved superior radiological precision with tighter control of HK axis and component positioning, significantly reducing outliers compared to the manual techniques. However, the question remains whether this achievement of alignment is truly translating into the functional outcome is questionable. And with this evaluation of the patient prompts, there is clear-cut evidence that there is no superiority of the functional outcomes compared to the conventional techniques. Even some studies showed small or inconsistent, but not statistically significant. like in Yu et al. And colleagues in 2025 confirmed that significant gains in radiographic precision, but found no consistent improvement in pain, function, or satisfaction. Few et al. In 2024 reported shorter hospital stays and lower 90-day readmission rates, yet also longer operative times and no sustained functional benefit. Chen et al. Showed similar survivorship and prompts between robotics and manual groups. So overall, there is a clear-cut score of positive score, which means all these studies are favoring robotics, but these are all favoring only in the alignment component. But in the functional component that is translating into the clinical outcomes, these are all again questionable evidence. So this is because of several confounders that can be seen. So it can be variability in the phenotypes and alignment philosophies like mechanical, kinematic, functional, and now restricted kinematic. Differences between image-based and imageless platforms, the influence of implant design, cementation, rehabilitation, and the surgeon's learning curve. And finally, multicentric heterogeneity that clouds the comparative analysis between the different robotic systems. So while the robot ensures where we cut, it cannot yet dictate how patients heal. Our challenge now is not just surgical precision, it's perioperative standardization, patient selection, and communication. Of course, this analysis has its own boundaries. Alignment was assessed mainly by the HKA angle, and outcomes were limited to the following prompts. Other functional domains and the outcome variables were beyond the scope of this review, and variability between robotic platforms could have masked real-world nuances. So where does this leave us in 2025? Robotic TKA now stands as a mature technology for alignment precision, which is reliable, reproducible, and quantifiable. But the functional and patient-reported outcome advantage remains small, situational, and inconsistent. This message is clear. That is, precision is here, but outcome must follow. The future lies in training better, adapting faster, and communicating clearer with our patients about what robot truly delivers. As we step into the next decade of arthroplasty, let's remember alignment is measurable, but satisfaction is human. Thank you, and these are my references.
Thank you, Dr. Dattatreya. I'll invite our judges for queries. Mohanty, sir.
Could you stop sharing your screen?
Yes, sir.
Dattatreya, do you use robot?
Yes, sir. At our center, we have the Mako and Willis, image-based and imageless robots.
Then why do you use robot if it is not transforming into better outcomes?
No, sir. In our routine practice, we don't use the robot for all the patients, but the center that I am in has the both the robotics available. But in my practice, the indications for robots would be those patients which would be difficult with the conventional, like especially the extraarticular deformities, or sometimes the conversion TKR of UKR to TKR, or if the patient has a post-traumatic arthritis, or if the patient requires a bilateral simultaneous, where the robot can deliver advantages like lesser soft tissue dissection and precise bone cuts. So in limited indications, I do prefer robots. So otherwise, as of today, in terms of restoring the alignment, robots have clearly shown the advantage. But in terms of this achievement of this alignment, truly translating into the functional outcomes, we are yet to see in the long-term studies.
You didn't mention anything about stability. You just spoke about alignment. What about stability? You know, alignment and stability. Robot also helps you to achieve stability, balancing the ligaments in extension, mid flexion range, 90-degree flexion. But you didn't mention anything about
Yes,
that.
sir. So the topic that was allotted to me was robotics, to be specific, alignment gains versus the clinical outcomes. So for this scoping, for this narrative review, the scope was I kept it limited to the alignment and the clinical outcomes. However,
Because
like you said, sir, the robot also does help us in terms of clearly assessing the gaps, both in flexion and extension, and also it helps to achieve the stability, and which can be quantified. The kinematics of the joint can be quantified by seeing it real time on the screen compared to the conventional.
alignment issues more or less we have solved, different variety of alignment you saw in the earlier lecture also.
Yes, sir.
Earlier presentation.
Yes,
But
sir.
it is the problem of, stability, which
Yes,
is
sir.
more important now.
Yes, sir.
So we have to achieve stability. We have to have a means of how to assess the stability and achieve a better stability. So what is your take on stability in the robotics that
Sir, in robotics again, it does give a greater advantage for the surgeon to adopt the personalized alignments, like kinematic, restricted kinematic, or inverse kinematic. All these personalized alignment philosophies are feasible with the help of robots. And in when a surgeon is adopting these alternate alignment philosophies, we tend to keep the components in
No, you
deviation to
didn't
plus or
understand.
minus 3.
How much manually when you do surgery, the classic teaching is that 1 to 2 millimeter lax on either side is
Yes, sir.
acceptable. So
Yeah.
how much you accept in robots when you are
Sir,
using?
in robots, especially, I would aim to balance the extension both medial and lateral. But in flexion, 1 or 2 millimeter opening on the lateral is usually preferred in flexion, especially in our Indian settings.
Okay. Thank you.
Thank you, sir.
Dr. Ram,
Yes, sir.
is there a difference in the post-operative pain when you use a robot versus when you
Yeah.
do a conventional thing?
Yes,
And
sir.
do you do less soft tissue releases when you are using a robot, and why?
Yes, sir. So in the early outcomes, there are individual studies which showed a clear-cut advantage of robotics in terms of delivering lesser pain post-operatively, because the soft tissue envelope is less disrupted when we use the robot compared to the conventional technique. So yes, in terms of pain, there is clear-cut evidence that with robotics we can deliver lesser post-operative pain to the patients. And sir, can you please repeat the second question that you asked, sir?
So do you change how much soft tissues you release when you're
Yes.
using a robot, especially when you're doing a kinematic alignment?
Yes. So again, it depends on the type of philosophy that the surgeon adopts. Like if we are the if I am the tibial first technique, there are certain alignment philosophies that I can adopt versus the if I am a femur first technique. So conventionally in conventional TKR, I always aim for the mechanical alignment. But if I want to adopt the personalized alignment like adjusted mechanical, where I take the cut to the tibia perpendicular to the tibia, same like in conventional technique, but I change the cut on the femur to adjust the to achieve the adjusted mechanical. So it actually depends
So
on.
if the patient is obese, morbidly obese,
Yes, sir.
would you prefer a adjusted mechanical alignment? Would you want to dial in a few degrees of varus alignment into the system if the patient is obese?
Sir, if the patient is obese, uh, first of all, robotics will give an advantage compared to the conventional because of the difficulty of the exposure and the soft tissue dissection that is required in conventional. And now coming to the alignment that we can accept some amount of varus that is in the overall alignment. But again, we should not deviate too much from the target of plus or minus 3. Otherwise, we'll have a risk of aseptic loosening or early failure of the implant.
Any
Okay,
questions?
Dr. Ram, thanks.
Sir, any questions? Dr. Pranay, you can start sharing your presentation.
No question, sorry.
Yes.
Audio clear, sir?
Yeah, can see your presentation.
Thank you.
Go ahead.
Good evening, ladies and gentlemen. I invite you to the Ortho showdown of CR versus PS knees. Who can make the knee disappear? I'm Dr. Prannoy Paul, and let's get started. In life, success may not always mean that the other person is satisfied. When it comes to TKR, what is true success? Is it a perfectly placed implant on the X-ray? It just not should be the absence of just pain, but it's the absence of stiffness, clicking, instability, or any other sensation that feels unnatural. If you look at the traditional scoring systems like the Knee Society score or the Oxford Knee score, they have something called a ceiling effect. This is where a large number of high functioning patients achieve maximum score on these scales, so that we are not able to discriminate between a good outcome and a truly excellent outcome. So that is where the forgotten joint score 12 or the FJS 12 comes into rescue. This has no ceiling effect and it can capture even subtle differences in patient perception. It assesses the joint awareness during 12 common daily activities. So the higher the score, the less aware is the patient and the better is the outcome. So when we are doing a TKR, we should strive for a forgotten knee. What is a forgotten knee? The patient should move and the artificial joint should move and feel like a natural healthy knee. The patient should be unaware of the knee during daily activities. This is actually linked to the mental comfort and life satisfaction. So a forgotten knee is the epitome of functional success. So our goal is to make the knee disappear. So let us look at the pre-match analysis. In the red corner, we have the CR knee. The strength being it has preserved more bone, it has more natural kinematics, better proprioception, and the weakness is that it is technically more difficult and there is a risk of future PCL insufficiency. Whereas in the blue corner, we have the PS knee, which has a more predictable range of motion, easier soft tissue balance, and it is safe from a future PCL rupture, but it has a weakness of more bone loss and other things. So traditionally, we've always been linking PCL with proprioception. We've been thinking that the mechanoreceptors and the innovation of PCL has been always been linked to better proprioception and a more natural feeling joint. So the hypothesis is that a CR design should provide a more natural knee. So today's match prediction is favoring more for the CR knee than the PS knee. But today's referee is going to be the FJS 12 scoring system, who is going to be a very tough referee. For the methodology, we did a targeted narrated review using peer-reviewed articles comparing PS and CR implants using FJS 12 as the primary outcome, looking at studies with levels of evidence 1, 2, and 3 in the last 10 years from PubMed and Scopus. This is the flowchart in which we went ahead and selected the studies and excluded some studies. So you can see the 7 studies that we looked at. You can see the number of patients that the studies included, the year of publication, the follow-up duration, and the results of these studies. The most recent study was in 2025 August, which was a systematic review and meta-analysis. So let us go ahead and do the analysis, PS versus CR. An unexpected plot twist. You can see that the PS knee has knocked out the CR knee in tonight's match. So the result is PS wins in tonight's match. The systematic reviews actually show that PCL preservation does not substantially improve proprioception post-TKR. PS implants were actually found to be superior to CS implants in terms of FJS scores. So this directly contradicts to the long-held theoretical benefit of PCL preservation regarding achieving a more natural feeling joint. So tonight's winner happens to be the PS knee. Now let us see why PS won today. A possible cause is that there is a study which mentions that after taking all the cuts and balancing, only 33% of the PCLs were actually intact. 43% were kind of attenuated, and 24% of the PCLs were effectively lost. So when PCL fails to function optimally, there occurs a paradoxical anterior translation of the femur over the tibia. This unnatural movement is subconsciously perceived by the patient and increasing the joint awareness. So how does a PS knee shines in this aspect? Here, the PCL is substituted with a post-cam mechanism. So PS designs can achieve more predictable and stable kinematics using their posterior rollback metabolism mechanism. So the idea might be that an artificial but a predictable stability might be more important than a natural but an unpredictable knee. But is today's verdict actually perfect? No. There exists extreme statistical heterogeneity across all the included studies, which means that the results might actually be affected by different study population, specific implant characteristics, or the methodologies used. Now, this is where things get actually interesting. If you look at the newer evidence, if you look at the studies comparing CR and CS TKRs utilizing highly precise techniques like kinematic alignment or robotic assistance, they found that there is no significant difference in the FJS scores between the two implant designs. So the new paradigm might be a precise execution like personalized component placement might be a more dominating factor overriding the design choice. So the real predictor, it's not the implant, it's the patient that matters. One recent study which looked at the high FJS scores after a TKR found out the criteria were a male gender, low BMI, and age somewhere around 63 years were associated with a high FJS scores after a TKR, and it was not related to actually the design choice. So what is the current evidence? If you are looking only at FJS scores from the recent studies, it actually shows that CS design is actually statistically superior. But this cannot be translated into a definitive general clinical recommendation favoring CS over CR. If you look at the traditional scores and survivorship, both designs have equivalent results. So we should focus on the quality of component placement, individualized kinematic restoration. This might actually override the trade-off between PCL retention and substitution. So the decision should actually rely on the surgeon experience and optimal intraoperative soft tissue balancing, looking at PCL viability. So the future of forgotten is precision. We should focus more on the surgical alignment, like component placement with precision, like robotics, and restore native kinematics. These factors may be more powerful than the CR versus CS design choice itself. So the future research, we need to resolve heterogeneity between the studies by doing more large, high quality randomized control trials, more subgroup analysis, and looking at the type of alignment to find the true differentiating factors. These are my references. Thank you for your patient listening.
Thank you, Dr. Prannoy. I'll invite the judges for questions.
So Prannoy, you have got some innovative PowerPoint presentations.
Thank you, sir.
Okay. So tell me, one factor where PS definitely scores over CR.
So one thing is CR knees, we cannot do CR in all kinds of knees. So if there is very gross deformities in extreme rheumatoid arthritis, or if the knee has some kind of previous trauma, then we definitely would have to go for a posterior stabilized knee. So the indications for a CR knee is actually limited. But PS knee, we have a more blanket criteria for PS knees. And so that is why one advantage of the PS knee.
No. See, there are some surgeons who also use only CR knees. Many surgeons, in fact, most of the surgeons, they are moving towards the CR knee nowadays. So, what the literature says about PS knee, how is it better, or PS surgeons, in what way they are better, and the CR surgeons, what way they are better? I'm telling patient-related outcomes measures.
Yes, sir. If you actually look at the evidence from the patient-related outcomes, it is actually same between the two outcomes. There is actually a study which was published in the article, the Journal of Neuroscience, which said that brain can actually adapt to a new processes. That is, if you look at the FJS scores at 5 years, and then you assess the same patient, the FJS score at 10 years, the score has improved, which means the brain can actually, develop an adaptation to the artificial joint, and it can, over time, it can feel like a natural joint. But the only criteria is that it should have a predictable stability. If there is a predictable stability to the joint, then the patient can improve the joint awareness over time. So when you look at predictable stability, then a PS design can, because of its design choice, it has a more predictable stability. Whereas a PCL, if it's retained, we do not know how predictable the outcomes are going to be in the long run.
You told about testing the PCL intactness intraoperatively. How do you test that intraoperatively?
During the flexion and during the gap testing, we feel with our own hands for the tightness of the PCL and how viable the surgeon can feel by himself if the PCL is attenuated or it's in the right tension. So then he can intraoperatively take a decision whether to go ahead with the CR design or to go ahead with the PS design.
So physically you test it by pulling the PCL with a probe or something like that?
Yes, so we can use a probe. In our center, we actually manually feel it with our fingers, looking at the tension in the range of movement.
The third thing is patients with a high BMI. Would you prefer CR or PS, and why?
We would actually prefer
More than 30, 35, say.
PS more because it has, like I said, it has a more predictable stability of a PS knee. This CR knee, we do not know. Sometimes it might give a good result, but it's a little bit of a dicey area. We do not know how predictable it is going to be in the long run if the BMI keeps on increasing, or if the patient develops some other trauma in the future. We do not know how predictable it is going to be in the future. So that is why a more predictable design choice would be a PS in high BMI patients.
Thank you.
Thank you.
Vidya.
Any other questions, Dhar sir? Okay. Anyways, thanks, Pranay. It was a nice presentation.
Thank you, sir.
I'll invite Dr. Pratik to share his presentation now.
Yes, sir. Thank you. Good morning. Good morning, my seniors and respected judges. Today, I'm going to say a review of literature on dual mobility in primary total hip arthroplasty. So, the primary total hip arthroplasty, wherever we see instability or a dislocation, we definitely, an orthopedic surgeon does not want to see that in his career. So, but the instability rate in the total hip in dual mobility total hip arthroplasty is also a second common cause of revision surgeries. So in 1970, Professor Gilles Bosquet and engineer Andre Rambert married the principle of Chanley's low friction arthroplasty and McFarland's large head to enhance the implant stability, and came up with a dual mobility hip concept. However, it got US FDA approval only in 2011. I went through the electronic database of PubMed, and cross references were reviewed. The systematic database was taken into concept. Systematic databases, systematic reviews, meta-analysis, and national registry data were gone through, and the studies with high citation index were chosen for my study. Dual mobility hips have evolved over the generations. The first generation faced a lot of failures because of the metal back and the coating of alumina. However, with the evolved generation, or the third generation has got a bi-layer coating of porous titanium and hydroxyapatite with a metal back of cobalt chromium alloy. And it is really standing the test of time. Dual mobilities are of two types, the monoblock dual mobility and the modular ones. The monoblock ones have a smooth inner surface of metallic shell which accepts the dual mobility articulation directly. It has got a benefit of large head to set in. And in modular ones, there is a metallic liner in between that, which limits the size of the use of large head size in modular dual mobility cups. However, it has an advantage of accepting screw holes and the other liners. Dual mobilities have got a unique complication with intraprosthetic dislocation rate. In the earlier generation, it was very high as 2 to 4%. However, the recent studies with the newer generation shows as low as 0 or 0.3%. And that is because the insert designs have changed over the time, which has given a sufficient cover of the head, which increases the jump distance. It has given a protective chamfers in the areas which was likely to be in contact with the femur cone, and it has improved the elasticity of the polyethylene cup. The jump distance is the crux of the dual mobility, as it has improved the stability of the hips, and we can see that the jump distance is in direct relation to the femur head offset, and the modular dual mobility cups, when we increases the size of the cup, the offset size also gets increased, and hence the jump distance in the modular dual mobility cup is not increased. However, in the dual mobility cup, which is the non-modular ones, the offset size is no relation to the offset size has no relation to the size of the cup increase, and hence the jump distance is constant, and it is very high. However, the range of motion, if we see, the range of motion is is larger in the modular dual mobility ones. There are a few concerns with the modular dual mobility liner, and the most important one is the mal seating of the cup. It has to be spot on, and if not, it can lead to corrosion, metal ion release, or it has potential for adverse local tissue reaction. The incidence is in the literature is shown as high as 5%. And also the adverse reaction to the metal debris, when seen by doing the metal ion level tests, it was very high, and it can be leading to metal corrosion or metal corrosions, and which can estimated median incidence of ARDM is 0.3 to 1.1%. So however, till now there is no clinical complication to it. However, we have to be very judicious in the use of modular dual mobility cups. So the indications where we can use this dual mobility in primary total hips are patients with more than 75 years, patients with neuromuscular disorder or cognitive dysfunction, who have failed prior hip surgery, or femur neck fracture, obese, tumors, stiff spines. In short, wherever we want insurance against the dislocation, we can use dual mobility hips. These are few literature which has shown better results in hip dysplasia. It has reduced the postoperative dislocation and got good results, good outcomes in tumor resection, tumor prosthesis, and in stiff spine nowadays. The literature has shown there is a shift towards the dual mobility, as it has got very good outcomes and results. Dual mobility in young and active population, there was a concern as the intraprosthetic dislocation and aseptic losing rate was as high as 2.7 to 4.8% respectively. Hence, in young and active patient, we have to be very cautious while using it. However, an Indian study shows that the survivorship at 5 years in young patient as well, it was 100% without any complications. So in the literature, there were many papers with minimum 5 years outcome of the small term outcomes, which has shown good excellent outcomes at 5 years. However, the concern is when we went through the registries of the American, Australian, as well as the European, all had concluded on a similar lining that the revision rates for the early revision rates have been increased nowadays, and the use in the reason to which they have shown is the higher risk patients, but where the dual mobility cups are more used, it is because of the femur neck fracture or some loose abductor mechanism, or the neuro cognitive patients are not very smart. So dual mobility cups should it be used in as a routine choice in total hip arthroplasty? So many of the literature is in favor of this. However, we when we see the overall literature, we can say this should be used restricted in the indications what we mentioned before, and also all dual mobility cups are not the same. So the take home message is a proper patient selection. We should try to use monoblock dual mobility cups over the modular ones. We have to avoid mal seating of the dual mobility cups, as it may lead to corrosions. The intraprosthetic dislocation has to be identified properly by buttonholing or the bottle opener effect, and it has to be reduced under general anesthesia after opening. And in young patients, if ever used, we have to monitor the metal ion levels, and always prefer a large non-dual mobility cup over a smaller modular dual mobility cups. Thank you.
Thank you,
So
Dr.
great
Pratik.
presentation, Dr. Pratik. So my
Yes.
question is, if you're using a dual mobility, can you take liberties with respect to the version, offset, and limb length?
With in the literature, I could go through in the literature. There was a paper which suggested that the dual mobility has got a better outcomes with the version, if we even if we are not in the safe zone, or we are so the version has given us liberty. However, not with the limb length, sir. Limb length is not going to
Okay, and if in a revision situation you are using a dual mobility, suppose the patient is having a bipolar which is unstable and multiple dislocations, now you are revising it. Would you prefer dual mobility or a constraint liner? In which situation would you prefer a constraint liner and why?
Sir, in if the patient is going recurrent dislocations in bipolar, and if the patient is having some neuromuscular or some cognitive defect or disease, then I would definitely go with the dual mobility cup. The indication for constraint liner is the last resort, and it has also in the literature when I went through the dual mobility with versus the constraint liner ones. So I could see that the constraint liner cups are uh, uh, the life of the constraint liner is only up to 5 years or so. So if it is a last bailout option, then constraint liner. However, if a patient is in early age, or some or if the patient is just in the scenario what you have given, sir, I would go with the dual mobility cups.
Okay, and in a younger patient, say you are doing an THR for an AVN in a 35-year-old patient, would you still prefer dual mobility?
No, sir. I would avoid to go with the dual mobility because of the two things, sir: aseptic loosening, metal corrosions, and the intraprosthetic dislocation. So these are the concerns which will prevent me from using a dual mobility. However, the literature has shown that in younger patient also, these cups have given a better range of movement and things. In case if I have to use a dual mobility, I would go with the monoblock dual mobility cup, sir. Otherwise, I would not go with the dual mobility. I would go with the standard large large head size.
Yeah, okay, okay. Over to Dr. Mohanty, sir.
Pratik, there is a classification which has been described for the biomechanical classification for the dual mobility cups. You didn't mention that. Do you know about it?
No, sir.
What
Sir,
is spherocentric? What is cylindrospheric?
yes, sir. Yes, sir. Yes, sir. I went through that literature. So there are
how
three
do you
types.
classify? Yeah.
There are three types, sir. One is cylindrospheric cup, in which there is a so one is spheric cylindric cup, in which sir, there are three types, sir. I'm not recollecting it totally, but
Okay. No. Okay. So there are three varieties basically,
yes, sir.
modular cylindrospheric, modular spherocentric and monoblock spherocentric. So there are three varieties.
Yes,
Anyway,
sir.
what is your second question is what is your indication of dual mobility in revision situation?
Revision situation.
You told about primary situations only.
Yes, sir. So I was restricted to the title, the primary hips. However, in the literature, in revision scenarios, dual mobilities have fared really well. So they would be the implant of choice.
Would you use in every revision, in spite of its controversies about dual mobility, all these metal ion, etc. Would you use in each and every revision, or in specific conditions that okay, it is preferable to use dual mobility?
Not in every revision, but in specific scenarios, if the primary was if the indications as the dual mobility because of neuromuscular disorder or cognitive defect or some multiple repeated dislocations, or if there is a weak abductor mechanism, in such scenarios I would use dual mobility. Otherwise I would go with a standard revision.
Third thing is that would you advise measuring the iron levels like metal and metal hips in dual mobility hips also?
It is strongly suggested in literature to use in younger patients, sir. To check the metal ion levels in younger patient.
Younger means how young?
Below 60 years.
Below 60 years.
Yes, sir.
Okay, above 60 years, you don't need to measure the metal ion levels. Okay, thank you. Thank you.
Thank you, sir.
Can I come back with the question?
Yes, sir.
Okay, so a basic question. When you use a dual mobility, which interface moves first, inner or outer?
Sir, sir, can you repeat your question, sir?
So do both the interfaces move simultaneously or one moves before the other?
Sir, one moves before the other, sir. The first one to move is the so the wear will be at the shell and the liner, not at the junction of the head and the liner, sir. The shell and the liner one will be worn out first, sir.
I'm not asking for the wear pattern. I'm asking for the biomechanics. Which interface moves first, and then at the when it impinges, the other interface starts moving.
So the shell and the liner will first start moving, and once it impinges, then the head liner starts moving, sir.
Okay, yeah, thanks.
Okay, Dhar sir, any questions? Meanwhile, Dr. Niranjan, you can start sharing your presentation. Thank you, Pratik.
Thank you, sir.
Okay, we can see your presentation.
Good evening, everyone. Myself, Dr. Niranjan. It's an honor to present in BOS Rising Star Competition 2025. Today, I will be talking about a classic yet evolving debate in total knee arthroplasty, patella resurfacing versus non-resurfacing, the 2025 position. Many of the patients report persistent knee pain after total knee arthroplasty, which is mostly anterior knee pain. So, how to manage the patella, whether to routinely resurface it or never to resurface it, or is there something which is a middle ground, which is called as selective resurfacing? The latest systemic review by Michael et al. And Usman et al. Shows how anterior knee pain and revision rate seems to be reduced with resurfacing, but overall patient reported outcome shows no difference at all. So for this review, I have focused on high-level evidences presented in literature from 2015 to 2025. I have included last 10 years of peer-reviewed studies, mainly RCTs, meta-analysis, and a few of the registries like Indian Joint Registry, Swedish Registry, and National Joint Registry from England. And so let's start with global practices. Resurfacing rates varies across the globe, showing mixed trends with almost 100% in some region and versus not at all in some other regions. So starting with US, almost 90% plus resurfacing rate is there, but now it started showing a decreasing trend over the period of time. Then comes the Australian registry, which is showing currently increasing trend over the last few years in resurfacing. And Swedish registry is completely contrary, which shows almost negligible, less than 10% resurfacing in today's date. and Indian Joint Registry, although the data is slightly older, 2019, it shows 45 to 50% resurfacing rate in India. So let's dive into current evidence, which starts with first, we will focus on 2 points. One is pain and function, and second one is cost and complications. So let's start with pain and function. Starting, patient who undergo patella resurfacing tend to have lower risk of postoperative anterior knee pain. In recent 2025 meta-analysis, which compared almost 50 papers, including RCTs and observational studies, and across all the major functional reporting outcome, including KSS, WOMAC, VAS scores, there is no significant difference observed between the two techniques. So this is also ROM is similar in both techniques. So this reinforces that resurfacing may reduce the anterior knee pain, but not necessarily translate into the better overall knee function or patient satisfaction. So then come to complications and cost analysis. The pooled analysis of incremental net benefits revealed no statistically significant difference between resurfacing and non-resurfacing approaches. Slightly, the data drives towards the resurfacing. But this should be taken into caution that this data refers to foreign registries, and there is no statistical significance between significance between revisions and re-operations between the two groups, which we can see on this forest plot. So in nutshell, anterior knee pain is reduced with resurfacing. Reoperation and functional outcome show no difference between the two, but revision rates are slightly higher, slightly reduced with the resurfacing. But what about the newer technologies? So now currently the world is moving toward something having robotics design, different kind of designs, alignment strategies, and different bearing surfaces. So according to this paper published in Arthroplasty today, in 2025, the robotics show improvement in patella radiological outcomes, but patient-reported outcomes are not showing any significant difference. Then other paper, which is this paper is showing there is a suggested that patient-reported outcome will show shorter-term improvement in anterior knee pain and functional scores, mainly in early post-operative period for robotics. And then the paper which is by DeCorto et al. Showed better functional outcome in non-resurfaced knees than the resurfaced one when the robotics is taken into consideration. So second factor comes the implant design. Does the trochlea matters? With the new implant designs in market, the which optimize the patellofemoral geometry and can neutralize the historical benefits of routine patella resurfacing. Patient receiving such implants have similar pain relief and function whether the patella is resurfaced or retained, supporting more selective approach to resurface than the normal one. So according to now coming to bearings part, according to Chan et al., rotating platforms prostheses don't have any superiority impact when compared in both patella resurfacing and non-resurfacing. At the same time, this should be taken into caution that if you are using rotating platforms, it can lead to a worse outcome if not aligned properly. Alignment strategies using kinematic techniques or mechanical alignment does not affect the patellofemoral joint pain significantly. So takeaway message is that there is no superiority over one technique over other. No consensus as of today for whether to do a patella resurfacing or no resurfacing. Registries also showed mixed picture around the world, but we can adopt a case-based approach as described by as described in this paper published in Indian Journal of Orthopaedic, which is taking into consideration factors such as HSS, patellofemoral assessment score, and cartilage wear patterns to provide patient best benefit out of it. And we should also take into consideration the cost factor. Thank you so much.
Thank you very much. I'll invite the judges for queries. Mohanty, sir.
Yeah. So, Niranjan.
Yes, sir.
You didn't mention anything about secondary patella resurfacing. Have you explored that from the literature? What is secondary patella resurfacing?
Yes,
What do
sir.
you
There are reports which shows that resurfacing done after some time of primary arthroplasty is also there, that are included in reoperations, and those rates were considering the cost effective analysis. The cost was slightly favoring the patella resurfacing.
No, what is the rate of secondary patella resurfacing in United States and all over the world right now? And considering that, is it, recommended that you should do patella resurfacing, more of patella resurfacing rather than avoiding patella resurfacing?
No, currently we can avoid the patella resurfacing by using methods like patella denervations and patella debulking.
No, that's
But
a different thing.
Yeah.
Okay. You mentioned lastly about the cost of the patella resurfacing. So how does it going to influence the surgeon's decision? Patella is not very expensive. It costs hardly, 4,000 rupees or some 5,000 rupees, within 5,000 rupees.
Yes.
The patient who is spending maybe about it, 1.5 to 2 lakhs of rupees. How does it matter 5,000 rupees for patella resurfacing? Does it influence the outcome?
No, the outcome won't be influenced by that. But considering the anterior patellofemoral pain is there or not, or HSS patellofemoral assessment score, if it's high, then in that cases we can consider going for patella resurfacing.
So what factors influence you that patella resurfacing must be done
So
in these kind of cases?
So if the HSS score is less than 40 or more than 40, more than 50. So if the HSS score is more than 50, then the patient is having majority pain of anterior compartment. So in that cases, if there is, except for grade 1 where we can go ahead for grade 2, grade 3 and grade 4 cartilage where we can go ahead with patella resurfacing. And in case the patient is having less than 50 HSS patellofemoral assessment score, then in that cases, if grade 1 is there, we can just manage the patient with patelloplasty, or we can go ahead in cases of grade 2, 3 and 4, we can go ahead with the patella resurfacing.
Finally, whether you will do a patelloplasty when you resurface the patella or you will not do. While doing a resurfacing, whether you will do a patelloplasty or not.
I will do it depending on the thickness of the patella.
Does it influence your patelloplasty, that thickness of the patella?
Overstuffing of anterior compartment might happen in case we have a patella button inside.
No, I'm asking of patelloplasty. What do you understand by patelloplasty?
Yeah, we in patelloplasty we just resurface. We just debulk the patella using.
Okay. Thank you.
Okay, can I ask a question?
Yes, sir.
Go ahead.
Yeah. Can you describe the pathology of a patellar clunk?
So, in majority of literature, it's the nodule which can cause a patella clunk, which is a fibrotic nodule, which may develop after the total knee replacement. And
So when do you see the patellar clunk? Which designs? Do you see it in CR or PS?
So PS
Whether
knee,
you see it
more amount of patella clunk because of the box we take, box cut we take.
Okay, and another question. Suppose you have a Indian thin elderly patient, say 60-year-old female, 60, 70-year-old female with rheumatoid knee. How will that influence your decision whether to resurface the patella or not?
If there is more anterior femoral anterior patellar cartilage wear, we will go ahead with the patelloplasty. And if there is no wear and patient's anterior knee pain score is also less, we can avoid it.
But it's an inflammatory disease, right? The whole joint is involved. Would you do the patella or not?
Uh, no, we can avoid it by doing just the debulking of the patella.
What is the what does the thickness of the patella have to do with your decision?
In case the patellar thickness is more and we added a resurfacing button over it, so it can cause a overstuffing of but anterior joint. So it can cause.
So how much overstuffing is acceptable?
So 9 mm thickness we can consider.
No, that's not my question. Suppose the initial thickness of the patella was 23. Can you raise it to 25?
No, sir. Sorry, sir.
Okay. Thank you.
Okay. Thank you very much, Dr. Niranjan. I think everybody presented very well, and all the presenters have prepared and done the review of literature very, very well. I'd like to thank our judges, Mohanty sir and Vidyanand Raut sir, for being here. Thank you very much, sir. And
Thank you.
best wishes for all the contestants. So we'll see the arthroscopy session on Sunday. Thank you very much.
Thank you. Good night.
Good night.
Thank you. Good night. Good night.
Thank you, sir, for the session.
Thank you.
Thanks. Good night.